And you can see there that kind of the trending, and we'll continue to now trend 2025 next to these two, but there was an uptick in COVID outbreaks that required reporting, a significant downturn in hospital-acquired pressure injuries, which is wonderful, and then also an uptick in privacy breaches, which I know they will be, I think, coming back to speak in greater detail about. Moving to page 3 of our report, section 5, the plan of correction monitoring data. So as of December 31st, you can see there kind of where we are from a finding standpoint. I'm happy to report, because we had ALCC, the accreditation committee, just last week, that a number of these have kind of turned the corner, and we will be finishing the monitoring because they've gotten to that threshold. There are a couple of them with the Joint Commission survey, specifically related to employee online training, and one related to pain assessment and psychiatry that they are very actively working on, that we're kind of doing a PDSA and kind of working like we've had a plan. We're struggling to get that required greater than 90% threshold for 3 consecutive months, and so we're retooling that and kind of looking towards next step. And the rest of this should hopefully get closed out here in the next month or two. Once we get above that 90% threshold, we have to wait for 3 consecutive months worth of data to know that that change has in fact been sustained. Moving to page, I'm scrolling too fast there, page 4, the complaint data. So no significant updates to this, but we will continue to track. There has not been, knock on wood, significant CDPH activity moving into the first month of the new year. And so the same can be said for the facility reported incident data on page 5 and 6 of 2023 and 2024 respectively. I will just comment that out of 93 total reported incidents, I believe 14 of them have been closed out. So the vast majority, greater than 80% of them, are still pending. And there certainly is the possibility, if I had to name the thing that keeps me up at night, is that when that general acute care hospital survey that's on the first page is something that's pending, they may simultaneously show up to do that and investigate and close out all of those open facility reported incidents at the same time. But we're doing everything we can to be ready for that, and it'll just be pulling documents every which way from Sunday. So with that, I will pause for questions.
Commissioners, public, please?
There's no public comment.
Okay. Commissioners, questions? I'll ask the first one, which is in your latter comment that you thought that maybe when they came to do the full hospital survey, they would close all these out, but has that been their, process in the past to then also look at the outstanding ones? Is that what they've done in the past?
Not for us, but that is our understanding from a webinar. They've been doing webinars with the California Hospital Association once a year, and at the last 2, they have shared that is their intent, because they are so dramatically behind everywhere across the board. And they did actually do this last summer when we had our 4A skilled nursing facility survey. There were 9 outstanding facility reported incidents, and they concurrently investigated those while also doing the survey.
Okay, well, that's certainly new information for us, and we'll see how that plays out.
And again, my understanding is they've each been assigned to a surveyor, but that they choose to come out irregularly.
Okay, great. There being no other questions, thank you very much for this abbreviated report, because there aren't any pending surveys and any closed surveys. So we'll move on to our next item, please.
Sure. Item 4 is the CEO report, Emergency Department newsletter, and newsletter.
Welcome, Dr. Arroway.
Good afternoon, Commissioner Chow, Commissioner Green, Commissioner Christian, and Secretary Morwitz. Susan Ehrlich, CEO at ZSFG, pleased as always to present our report. I'll start with the narrative report. As usual, we had a lot going on this past month, and the report opens with Mayor Lurie's visit to ZSFG. This actually happened before he was inaugurated, and it was a very inspiring visit. He actually mentioned the visit in his opening inaugural remarks. It was so meaningful to him. So that was a great start, and we were very excited to welcome him. In the equity category, our work in preventing heart failure readmissions was recognized and awarded not once, but twice First by the Safety Net Institute and the California Association of Public Hospitals, and then secondly by the Joint Commission. They awarded this work the Bernard Tyson Equity Award, which was incredibly meaningful. Both are meaningful, obviously. This one because, you know, I knew Bernard Tyson and he was an incredible champion for equity and for the work that we do. And it is the only award that the Joint Commission gives for equity across the United States in the year. So that is great. And there's more details about that work here. As you know, Proposition B passed by more than 72% of San Francisco voters. We were very, very grateful for that, that award. That will provide $205 million in healthcare infrastructure improvements, much of which will happen at ZSFG. It will make a lot of mechanical, IT, kind of the basic infrastructure improvements that we need so much, including our new chilling and cooling tower, which will allow us to keep our Building 5 cooled during heat events, which we just experienced this past fall. So that's very important. We will fund a full seismic retrofit of Building 3. That is the building where Carr Auditorium is, where anatomic pathology is, and soon to be 35,000 square feet of usable office space, which we greatly need because of the renovations that are happening in Building 5. And then last but not least, it will help us complete the PES renovation that is scheduled to be occupied in the spring of next year. So very exciting, and we're very grateful. Our 4A skilled nursing facility was recognized as one of the top short-term skilled nursing facilities by U.S. News and World Report. We are part of 19% of skilled nursing facilities that falls into that category, which is very exciting. I'm not going to say a lot about flow because you'll hear about it when I present the data, but you'll see in the narrative some of the many things that we're doing to try to address the flow challenges that we're experiencing right now. I do want to call out two of our, well, one brand new leader and one leader who is in a permanent new leadership role. So our new Chief Operating Officer, Sabrina Robinson, she is here in the crowd. We're so excited to have her. She's in her third week.
Would you like to stand up so
Yes,
we
please.
can see beyond Susan here? Okay, thank you.
Very excited to have Sabrina. No one is more excited than I am. She comes to us from South Carolina with lots and lots of experience in hospital operations. You can read more about her, and you'll hear from her, I know, as time goes on. And then Chauncey Jackson, who was the interim Deputy Chief Operating Officer, has been made permanent in this job. So we've got a great team supporting our facilities, capital, radiology lab, all of our support services in the hospital, and I couldn't be more delighted. And then in the another topic in our developing our people, 200 nursing and other staff from across the department attended an all-day addiction care symposium in Carr Auditorium. And this was one of the many events, but one we're highlighting today, that helps our staff understand and respond to substance use disorder treatment, recognition and treatment. So this is a really exciting part of the work that we're doing to promote recognition and treatment in this area. I think I'll stop there. You can look at the pictures of the beautiful gingerbread houses that I was one of the judges lucky enough to judge. It's just incredible. Our team is so skilled in taking care of patients, and you just never know what additional skills they bring to the table. But creating elaborate gingerbread houses is really definitely one of them. I'll pause there before I go on to the data.
Commissioner, question?
Thank you. Thank you for the report. It's good to see you. Just want to congratulate you and your team on the equity work that you've done and the award. That's extraordinary, the only one, and from the Joint Commission itself. And we've been hearing about the work for years, and it's great to see that, to be able to see what you've done, but also to know that it is seen and recognized uh, by the Joint Commission. So congratulations on that work and the continuation of it. And thank you for the tour of the campus a little while ago that Commissioner Salgado and I had along with Mr. Morowitz. It was very helpful in giving context to all of the work. But so now you were talking about the cooling tower, and I can see it in my mind, the cooling tower. And so
Excellent.
thank you for your time for that. It was really useful. I hope you understand how useful it is to us.
We've been doing a lot of tours recently, and it's always such a pleasure and delight to take you and others around because there's so much great work that goes on, and it's great to have others, kind of see and touch and feel it in the same way that I do every day.
Yeah, that was really my first time in San Francisco General, and I was deeply impressed at it's just this beautiful modern facility, and the organization and the smiles on the faces of the people that we passed just in the hallway and the work. Wonderful space with a wonderful feel. So really, really impressed and grateful for the city that we have this resource.
Me too.
Yeah, I bet you are. And I just want to say welcome to the new COO. Wonderful to have you here and looking forward to hearing from you in the future. Thank you.
Great. Thank you.
Thank you. Commissioner Green?
Yes, well, I think it's a testament to this team that you were able to recruit such amazing people. Chauncey Jackson gave such a great environment of care report in one of our other meetings, and what a talented individual. And reading your CV, it's incredible. I don't think you'll be sorry you came to California from South Carolina. This is just a wonderful institution to work with. And, Commissioner Guillermo and I met with the mayor briefly on Thursday, and the first thing he said was how impressed he was when he came to the general. And from what he said, it sounded like seeing the NICU and seeing what you are doing has really, I think, helped him create what his priorities are in terms of what he wants to see change in terms of substance use disorder, the street teams, family services. So I think it had a major impact on him that he brought up in this meeting, and I wanted you all to know that. So, and it wasn't last time you hear that all the peds and women's care people got all the gingerbread awards. Kind of makes sense when you think about it.
Well, so to be clear, all the different areas compete against one another. So it's a friendly, but, pretty stiff competition. So labor and delivery, peds, the NICU, 5M Women's Clinic, they all put their, efforts into these houses. And it's an incredible competition.
But does anyone eat them?
No.
Next year, please invite me. I will do it next year.
When you see them, they're so elaborate. You can't imagine.
You can't imagine tearing one down. I
No.
know. Great. That's all I wanted to say.
You always wonder also what the Fairmount does with all their gingerbread after
Don't know.
after Christmas. But I did wonder about the Tyson Award. Is that a single award, or they give a number of these, or this is the only one in the United
This is
States?
it. Yes.
Wow, that should be highlighted. It's the
Yes,
award.
The award, yes.
The award.
It's, it tickled me when we got it too, because when they were here for our triennial, they actually encouraged us to apply for it. They said that this would be an excellent candidate for an award. And sure enough, we were awarded it. So it was really nice.
Great. I think that by itself, and the program, of course, has shown justification that, and we know in the city, it is so important to be able to really dissect and really understand the needs of the different populations that we're all taking care of.
Yes.
It's a shame that we seem to be having a change of direction from our national government.
We're not changing.
No.
And I will note that that the work that they did benefited all of our patients. It's just that one group needed to have more an improvement than others. And so it was a change in practice, or a number of different practices that benefited all of our patients, especially Black African-American men.
Yeah, no, an excellent, example of why it's needed. Thank you. I did forward a question, and that was sort of on the current issue of Walgreens and
Yes.
the need that we've been using the adjacent Walgreens and where we are now, because I can recall a number of years ago, the problem with our pharmacy and backup and outpatient waiting and so forth. So where are we?
Well, I will say to start that our outpatient pharmacy cannot pick up all the work from 12 Walgreens closing, because it is 12 closing across the community. And Dave Smith, who is our DPH Director of Pharmacy, is working very closely with Walgreens to have a plan. And there is a very elaborate plan. All of the pharmacies that are closing are posted. Each pharmacy that's closing is paired with another pharmacy that will take on the prescriptions of the patients who went to that pharmacy. Patients can, of course, choose a different pharmacy if they want to, but there's a lot of communications going out to patients, to providers throughout the network. So as much as we can, there is a plan to mitigate the effects of all these Walgreens closing, and that is driven by Dave Smith, the pharmacy director.
Good. When is the actual closing, or is it sort of staggered, or is it that Walgreens is going to close them all at one time? And
I don't know the dates. Is it all in one?
It's all at once. I think it's like February
It's,
1.
I know it's soon. It's early in February, but I'm sorry, I don't know the dates.
okay, I think at our follow-up meeting, it'd be good to see where we are with this, because I certainly remember a number of years ago, our pharmacy at that time couldn't handle it, and that was the subject of many months of discussion, especially by the public, that really came before the commission and spoke to the issue of access. And we've not had that since we've been able to have a real network of pharmacies along with our own that was caring for our patients. So
Yeah, this is very unfortunate, and I can't imagine that there won't be patient impact. I think Dave tried to reach out and see if there was anything that could be done, but by then it was, they made the decision. It was a done decision.
all right, so we can have a follow-up site next month as to, how this is progressing to see if we can stay ahead of this.
And if I may, Commissioner Child, this is actually a full health commission issue too. It might be something to bring to the full commission's attention and speak to it through the director's report, because although this certainly is pertaining to the ZSFG, it also relates to
The
other
whole network.
neighborhoods and the networks, right? So with your permission, I'll forward that to
Sure.
Director Colfax.
The more information we can, then to continue to be able to have transparency will help, so that the public also understands this is an issue we're all working on for access.
Yes,
Okay, thank you.
thank you for asking.
Let's proceed to our data.
Okay, yes. Our new and improved data report. I have all the questions that you asked. Most of them I will respond to in the data. There are several that aren't really directly related to the data report, so I will talk about those when I'm done, or you can ask me as we're going along. Okay, so part one of the data is the True North scorecard key performance indicators, and part two is the flow data, just to start with that. And with each of these, what I'll do is remind us what the green and the arrow mean and where we are, and what are the countermeasures that we're taking to address the ones that are off target. So the first one, departments driving equity, you can see that higher is better, and we are in the green, as we have been for most months. And this is what we're trying to do is increase the percentage of departments with an active equity driver in from the PIPS meeting, and we're doing extremely well there. Sepsis bundle compliance is the next one. Here, higher is better, and we are in the red. We don't have a change from last year because this is a new metric. So we are off target. Just a glance at the way the data look show you that we really haven't started fully our improvement efforts here because there's so much variation in the run chart. Primarily, this is because this team envisioned a care pathway built in Epic, and there are significant delays with doing that because of the resources that it takes to do that. And our IT team is busy keeping the lights on and going live with other Epic projects. And so that's just not in their wheelhouse today, although it will be over the longer term. So what we're trying to do is figure out smaller things we can do along the way. And the ED leadership are working on a revised sepsis order set in the interim to try to address our performance here. Because again, recall that we think this is a problem of documentation rather than actually not doing the work, but we have to validate that. So that is our interim countermeasure on that one. Hospital acquired pressure injuries, lower is better, and we are in the green. And in fact, we're doing so well on this one, we're going to be moving it to a watch metric in 2025. So that's a really happy story with that one. Falls with injury, lower here is better, obviously, and we are in the red. We've actually had an increase in almost 42% from last year, which is really not good. So in 2025, we're going to refocus our efforts on falls with major or moderate injury. And even though these are a very small, less than 5% of all falls, they affect patients in a greater way, and it allows us to focus our efforts more specifically. Our RCA for root cause analyses for falls continues to highlight a few things. The difficulty of balancing patient autonomy with wanting to keep them safe, patient privacy, and falls interventions. We do have one area, H7678, that is a particularly high-risk area because this is our ACE unit, acute care for elders unit. And they've used the daily management system through a technique called K-cards, which encourages rounding that helps focus on patients at risk for falls. And they've had no major or moderate events in 2024. So we think that's a good way to focus our efforts for a next step on this one. Ambulance diversion. So here, lower is better, and we are in the red. We have had some improvement since last year, 6.7%. And even though we are not at target, mainly due to challenges with ED boarding and high volumes coming into the ED, I'm happy to report that in January so far, we're almost done with the month, we're at 57.8%, which is much better than we were in January of last year. So overall, I'm looking at this with optimism because overall our performance has improved. A lot of the improvement is tied to our ability to staff better with nurses in the ED. The challenge continues to be boarding and high volumes coming into the ED. So we're doing the best we can despite kind of a challenging environment. Left without being seen is similar in some ways. Here, again, lower is better. We're in the red. We've had a moderate increase or a moderate improvement from last year, about 3%. And here, we're really looking forward to hiring nurse practitioners who will not only help our efforts during the day, but also at night, where we tend to have higher rates of leave without being seen. And those NPs are one's already started, some more onboarding. So we really think that's going to help us quite a bit with this work. That front part of the emergency department where the walk-in is and we have our triage efforts, it's so busy. I mean, anytime we go into the ED, it's almost always the busiest part of the ED. And so there's a lot of effort in making sure that patients are seen quickly, evaluated, and either sent to urgent care, sent to primary care, treated and released, bedded in the back. You know, there's just a lot of really complicated work going on to see patients in that area. Okay, perioperative area, OR add-on cases. So here you had a question about this, and I'll address it in talking about this. Here, higher is better. So basically what we're trying to do with this metric is we want to make sure that the urgent cases that have been identified get done within 24 hours. So if they are a U24 case, we want to make sure they're done in 24 hours. It doesn't look like we're improving from last year, but what we are seeing, this was launched on October 1st. So it's a pretty, it's still pretty new. And though we're not seeing the percentage of U24 cases in 24 hours change that much, what we are seeing is that our length of stay for these patients is dropping by 1 to 2 days, which is hugely important, right? So even though this metric doesn't look so great, we are seeing improvement in other areas. So we're very encouraged by that. Obviously, we'll keep tracking it, and you'll see these data every month, and we'll see, how that 9th OR continues to address our length of stay as well as the U24 cases. Okay. The next one is specialty clinics and third next available appointment. Here again, we're in the red. Higher is better. And we we're basically, our performance hasn't changed that much. So here we have rising demands, including a high number of out-of-network specialty care referrals, no-show rates in combination with issues with just the heavy volumes that these clinics face. So we have a new grant from the health plan that is going to add night and weekend clinics to help us just get more patients seen. And the other thing that we're doing now is we're utilizing staff with work restrictions to come together as a SWAT team, basically, to look at the work queues that we have in the specialty clinics, because they're big and it makes it very hard to manage this. So they're a SWAT team coming together to try to address those queues and really understand what the baseline demand is going to be. Lower level of care. Lower is better. We are deeply in the red. We're worse than we were last year. So there's a lot to say about this. I think this is the one metric where we have consistently been more off target than any other metric. We have, in March, you will hear about our Hoshin Conry for this year. We've really tried to focus our efforts to be very specifically focused on the things that will most help us bring down lower level of care. We are working very closely with the Laguna Honda team. They just took 2 patients today, but we're focused on reducing the time for review, reducing the time it takes to transfer patients over. There are multiple efforts that we're doing to try to address this, and it's very challenging. We have anywhere from 40 to some days 60 patients on our med-surg unit who are waiting to be discharged. So more to say about this one. It's really multifaceted. Okay, physical assaults with injury. So I have to say I looked at this and was very alarmed. So as I'm sure you were when you saw this big spike. This is, there are more physical assaults happening, I think, throughout the network as well as at ZSFG. And it is a busy time, and patients coming to us are more acute, which is part of the underlying problem. So in total, we have 16 physical assaults. They are primarily in psychiatry and med-surg. In med-surg, 3 of the patients caused 7 of the incidents, all 7 of the incidents you saw. So it's not just one patient with one assault, it's more. And psychiatry was a mix of acute psychiatry and PES. And those are really the 2 areas where we saw this big increase. The ED had a few assaults with injury, but it wasn't that different from previous months. So what do we notice about these, and what are we doing about them? So first of all, every one of these assaults is fully analyzed to try to understand the root causes of why it occurred. On med-surg, 2 of the 3 patients were on psych holds. And so, you know, we think that there was some mismatch between the patient's needs on the unit and the staff who were there to help. Now, we do have a BERT team that rounds. It's not quite as intensive as the ED where they have one team there. But one of the things that we're trying to do is streamline the escalation pathways on med-surg to make it easier for the frontline staff to ask for help and to make sure that they're getting what they need in addressing this. And then in psychiatry, what we're doing is restarting CPI training. So this is de-escalation training to try to address the root causes that we saw there. So we're very concerned about this. We analyze the incidents to try to understand better the root causes, and we have countermeasures to try to best address those root causes. And then the last one in this series is the denial rate for hospital billing. And here, lower is better. We are in the red. We had some improvement from last year, which is great. And in fact, in December, our denials rate was on target, 15% below our target of 15.6%. This is good, but it's not, we still haven't gotten to where for the whole year now we're on target. There are a couple of reasons. One is the significant volume and the dollar loss that we have due to denials for patients being at the wrong level of care. So inpatient level versus observation level, for example, and come and go surgical cases being hospitalized when they should have gone home. So those are 2 big reasons for that. And we've encountered some system logic in the Epic billing approach that's been incorrectly configured. And so that's resulting in some partial denials with the health plan. So we're working on addressing those 2 things with a couple of different countermeasures, but we're feeling good about moving ahead in that area. And then before going to the flow data, let me, so I think I addressed your question about falls with injury, Dr. Chow, and physical assaults with injury. We talked about Walgreens. We talked about the sepsis bundle. We talked about the additional OR and the perioperative add-on data. So I think we addressed all those questions that you asked, but tell me if we didn't before we move on.
Well, I think we're okay. Oh, Commissioner Green.
Yeah, I think it's so informative what you told us about the denials, but it would be really interesting to understand if you know certain plans, because as you said, we have a lot of out of network, at least in the outpatient side. It'd be interesting to understand really who the payers are, and since you know we have the San Francisco health plan, you know what kind of collaborations going on to minimize the administrative burden both on the plan and on you know the general.
A lot of times what happens is that patients will come in through trauma, you know, into the ED through trauma, and then they'll want to follow up with the people who took care of them while they're in the hospital or the ED. So that's the genesis of it, and it's hard to, you know, we want to repatriate them to their systems, but, you know, for one reason or another, that doesn't happen before they get into the specialty clinics.
So the denials are, I mean, it would really be helpful to have just more granular information on the denials, especially if it's mainly not within our own system, but people, as you say, that come in with trauma and so forth.
Yeah.
It's a huge problem. It's becoming greater because all the plans are using AI to create denials. We've seen a huge uptick in denials, even for global things like global obstetrics care. Like, what are you denying this for? You know, it's one fee no matter what happens. Here's the baby. You know, we're still seeing this, and it's you know, I think it will be interesting if we can be preemptive in any way, or at least analytic, so that we know who the greatest offenders are and where we have latitude to work with systems like our own, and when we may be hitting a wall because there's so much of this going on and escalating as time has gone on.
Yeah, thank you for that. Yeah, you're exactly right. Plans are ingenious. Okay, I will move on to the flow data. And the next chart, you see the ED average volume, and it's going up. We're very, very busy right now. And you can see over time, the prior fiscal year baseline is going up. So that puts a lot of pressure on the folks in the ED to see more and more patients. The PES, average daily volume, I think we've talked about this before. In PES, when the volume is down, it means that it's hard for patients to get in and there's poor flow upstairs in 7B and C. And so this spike up in volume is actually something that we like to see because it means we have better flow and we're better able to accommodate patients in PES. Inpatient, average daily admissions and discharges, you can see that small difference between the admissions and the discharges. We've had a lot of debate about what this is, but I think, the reason when we're admitting more people than we discharge, that's at least part of what's contributing to us having so many lower levels and so much boarding is that we're taking in more volume than we're discharging in any month. Okay, so this very busy chart is we're trying to address your question about, or your concern that one line doesn't really represent, all that we do in this area. And when you look at the data disaggregated, you can see, in fact, it does not. The problem here, even though you can see the difference between admissions and discharges on the two different areas. So we've bundled nursery, NICU, and peds into one group. So we have admissions and discharges for that group, and then admissions and discharges for L&D. The problem, though, is that a lot of times patients will be admitted to L&D, but because of space issues, they'll move over to peds and be discharged from peds. And so we don't have any way of disaggregating that in the data at this time. So it's very hard to compare the admissions to the discharges because of that movement. And, which is the right thing to do because we're trying to use the space we have effectively, but we'll put a dyad into peds and they'll be discharged from there. So just so you know, that's what's going on in the data here. In terms of your question about NICU and peds days, seems short. So there are a couple things going on here. It's definitely the case that the more complicated patients are transferred to Mission Bay. And there's a whole algorithm for doing that. And we work very closely with Mission Bay to make sure that, we're not managing patients that they're more effective in managing over there. And we do have some longer lengths of stay for patients who with substance use disorder. So there's a lot going on in those data, but just to the issue of Mission Bay, yes, we are sending patients over there. Inpatient psychiatry, inpatient admissions and discharges, the fact that these lines are so very tightly tied means that there's a lot of triaging about who gets admitted. There's about 15% of the people who come to PES that are eventually admitted upstairs to 7B and then go to 7C. And more admissions means there's more flow. So this is really good to see. And you can see that even more clearly in a chart that's coming up, and we can talk about that in a minute. Okay, average daily peak medical ED boarding. This number is not great. So this means that of our 59 beds in the ED, in November, we were about 24 of them were occupied with boarders. And in December and January, these numbers are going up. So they'll look more like what happened in December and January of last year. So up around somewhere between 30 and 40. And, we've talked a lot about those, the dynamics of ED boarding. We have ED boarding because we have med-surg lower levels. And it's just very clear, the connection between those two. Inpatient average length of stay. I think the main thing that I note here is the growing length of stay on med-surg, which is what we're going to be addressing in our work going forward in 2025 in our HOSHN. 7.5 days in med-surg is just way too long. We need to get it back down, at least down to the 6th level, and we'll have a number of countermeasures for doing that. And it's really nice to see the psychiatry length of stay coming down pretty considerably. So this is the chart I was referring to, the lower level of care. You can see the remarkable drop we've had in lower level of care days on psychiatry. I can't say enough about what a big deal this is to be able to accommodate more patients. And we've really looked at what is going on here. And the best we can say is two things. It's two things. One is that we're finally seeing the investment that behavioral health services is making in beds is having an impact on the patients in our acute units being able to be placed. That's one thing. The second thing is, we talked previously about Angelica Almeida, our Chief Integrative Officer. The impact that she's had on being able to navigate some of these complex discharges out of our inpatient unit cannot be understated or overstated. Having that person who understands both sides of the system to be able to navigate the complexities has been very important. So those two things together are important, and it gives us some insight into what is needed on the med-surg side. I think similarly, we need to do some investment in that kind of thing with behavioral health, with WIPIC, with other parts of the network. ZSFG to Laguna Honda transfers, these data are pretty old. I think we're approaching about 3 patients a week now on average, which is great. We're making slow and but steady progress. I won't go over this very busy table unless you would like me to, but it just elucidates some more of the data. And then you can see the increasing demand for med-surg over time, and this gives you a sense of the boarding over time in months, and you can see that it's a steady line going upwards. That is the end, and I've done a lot of talking. There were 2 other questions. I'm going to need to give you more information about the BERT graph, but I did want to mention that the age-friendly sensory cart is in the ED. It is not upstairs. And I think the data you were talking about is actually in the upstairs. I'm fairly confident that cognitive decline is a driver of those incidents, but we can get you more information on that. And then the last question, well, I'm not sure there are any funding streams, and of course, Drew would be best to address this question too. I think the good news here is that most of the funding streams that we're concerned about have to be implemented through Congress. And so there are many, there are in fact scores of pages of proposals that the Ways and Means Committee are considering that could affect Medicaid in various ways. Some of them are actually directly targeted at New York and California. But the good news is that they have to go through Congress. So there'll be a vetting process of implementing them. And there are a lot of stakeholders in this that I'm sure will make their needs known. And there are congressional representatives whose the members and the people in their districts would be very affected by them. So there's not a lot to say about this other than probably big changes that we see will take time and they can't be executed by a presidential order.
If I may jump in, thank you, Dr. Ehrlich. Director Colfax and Dr. Obaba are figuring out how best to update the full commission on a regular basis as policies from up high hit the streets. And I think it's whether it's quarterly or as it's happening, it'll be in the director's report, or they'll have special policy updates that will occur there.
Very good. Any further questions from commissioners? Thank you for responding so thoroughly to the questions that we were able to submit. This Monday schedule is very hard on everybody, but I must commend our staff for really taking up the challenge and getting the responses so quickly for all of us. So thank you very much.
Great, thank you. Really appreciate your support.
Thank you. Okay, we'll move on to our next item. Please.
Sure. The item 5 is the hiring and vacancy report.
Good afternoon. I'm Kim Knox Mitchell. I'm the HR Ops Manager for ZSFG. Emma Perez usually shares these updates. I have brought her here today just to make sure I stay on the assignment. I'll be sharing December updates with you. If there are any questions outside of December updates, we do have a few folks here who are able to answer those questions for you. You have in front of you the data and the metrics, as well as a summary report. I won't read the entire document, but I'll just do a few highlight callouts. I will read number 1 because we have a note in there for you. Total hospital vacancies for December were 7.06% compared to November's 2024 vacancy rate of 6.27%. We've hired a total of 38 employees between December 1st and December 31st in various classifications, including RNs, and we had 7 separations during the same time period. So this is the note. Our data team has historically pulled metrics from 2 separate data sources. That could impact our percentages, creating some variances in reporting. With the holiday season, this could mean that if delays in submissions of requests to hires occurred, those positions would still be deemed vacant when they had candidates selected and moving through the process. For our January report out, we anticipate our data will be pulled from 1 single source. Number 2, you see the RN vacancy rate has remained at 4.0%. And then there are several things that we continue to do to mitigate the challenges in hiring nurses. Just to call out, we have ongoing partnerships with several nursing schools, and you see those listed there. In addition, we partner with Workforce and Career Development that focuses on internal development and offers information sessions on nurse reassignments. We were able to hire 15 nurses at ZSFG in December, and those also included our reassignments. We had 1 hire of a P103 was hired last month to fill the gaps in vacancies. That was an external hire. We continue to have our HR weekly and monthly vacancy meetings with our hospital leadership team and hiring managers. And I will say, I've been here for 4 months and those are hugely successful. They make a difference for us in hiring. Moving to number 4, our hiring status. I won't read everything there, but you see the emergency care unit, 6.6 full-time vacancies, and 4.6 of those were RNs, with 7 selections, and we've got target start dates in January, February, and then later in February. For our critical care unit, we've got 2.6 full-time vacancies, 1.46 of those are RNs. And again, we have selections made with target start dates in January and then in March. For our med-surg unit, we've got 10.6 FTE vacancies, 2.75 of those are RNs. We've got 8 selections, and then our target dates are in January and February. No hiring for OR. I'll pause there. Any questions? For our RN training updates, our neonatal training program is anticipated in early February with a cohort of up to 4. Likewise, our med-surg training program is anticipated with staggered start dates in January and February with a potential cohort of up to 10. Just a few highlights on non-RN positions. We hired 5 hospital eligibility workers, 2 pharmacy technicians, 2 certified nursing assistants, 2 medical evaluations assistants, and 1 senior account clerk. And we did get a question from Commissioner Chow. The reason for significant non-retirement separation compared to prior years. The team and I did a little bit of research and we couldn't find any significant reasons. The majority of separations were personal and medical conditions, but nothing significant that would point to why there was an uptick.
Okay, thank you.
You're welcome.
Commissioners' questions. My question was concerning the fact that we know with all the efforts in hiring, retention is really important.
Yes.
And it just looked like you had 7s and 8s during the months of July through October. And glad to hear that most of it seemed
Yeah, we couldn't point to anything
okay.
significant for you.
Because if there were some common dissatisfaction, then that would be something that would be
Absolutely,
really important to deal with. Okay.
absolutely. We do have a team that does exit interviews. And so again, we didn't find anything significant in those.
Good. Any questions? Yes.
Thank you. So great for you. Thank you for noting the partnerships with the nursing schools. Are those long standing, or are these some of those more recent?
I think the majority are longstanding. Some are new, but I think the majority are longstanding.
That's great. And I don't know whether there's any possibility for expanding partnerships to other nursing schools. I don't know whether that's happening.
I'm sure there is. I'll check with the team. I'm sure there is. Yeah.
Thank you.
The more the better, right?
Yeah, definitely, definitely. And the hiring vacancy rates for I look at the health worker category a lot because that is what I'm most familiar with in my work. And do you have anything to say about how that's going or what you anticipate in the future?
Yeah, so we did create some updates for the commission in October, but I can get those for you. Yeah, we did have really a good explanation of the project that the team is working on to specifically address that.
I'm sure I can find it.
Yeah. If not, let me know. I can
Okay.
certainly get that for you.
Okay, thank you.
Yes.
Commissioner Green, any question?
Oh.
No. Okay. Thank you again for our very positive vacancy report.
Yes.
Sorry, really quick. We do have our recruiter here to answer some of the questions about the schools.
Oh, so sorry, we do have the recruiter here to answer questions about the schools, if you'd like more information about that.
Oh. Okay.
Hello, everyone. My name is Tina Hennett. I'm a recruiter. I've been a recruiter here for DPH since 2016, but my career has been in recruiting for a very long time. To answer your question specifically, we have had a very long-standing relationship with the schools. The schools that were listed were just kind of a snapshot. I have been reaching out to all the schools have had a very long-standing engagement. Merritt College is one of the ones that are really, happy to work with us. UCSF, goodness, USF. I've reached out to the HBCUs that have nursing schools, and some of those are, for me at least, longstanding. Now they know I work for DPH. They're now working with me on that because prior to that I was with Kaiser.
Thank you.
Thank you.
Thank you very much. Yes, Commissioner Green.
Yes, something just struck me. I know that one of the ways other hospitals try to recruit nurses is to have the nursing students come, and actually stand in rooms like during deliveries and things like that. And I wondered, how involved the general is with actually bringing the students on site and either having them as observers or what kinds of programs that, might encourage them to take a job here as opposed to another site.
Would you like to respond to that? Somebody? I think the question is how we are relating to these schools. Is it, and do we have on-site, educational programs? I know, for example, USF has rotations, for example.
Commissioner, I was going to answer. Hi, Tina, it's Jillian.
Oh.
I'm here.
Hi, Julia.
Yeah,
Hi, how are you?
somebody answer.
Jillian Otway, Chief Nursing Officer, and we do actually have rotations here at the hospital with all of the programs that we are contracted with. They have the students here on site in all of the clinical areas, in addition to doing internships where we have students that may do a concentration, for example, in labor and delivery with Kelly Brandon, our clinical nurse specialist, as well as critical care and in med surge.
Have we ever done like exit surveys for these students to find out if, what we can do to enhance their interest in then when they graduate joining the staff here as opposed to making other choices?
We have not done those interviews, but I will tell you that for the most part, those students are all interested in working with us after being here for their rotation, their clinical rotation. I think, and I know HR can respond to this, we have a large number of applicants that are interested in coming on board for training programs. And I think we probably have more applicants than we do have vacancies.
Excellent. Thank you.
Very good. Thank you.
Thank you.
Shall we move on?
Yes,
Okay,
yes.
and-
Just make sure we didn't have follow-up
Oh,
questions.
sure. And congratulations to Ms. Knox Mitchell. I believe that was your first time presenting, and you did it. That's great. We can move on to the medical staff report.
Good afternoon, Commissioners, Commissioner Green, Commissioner Chow, Commissioner Christian, and Mr. Morowitz. I'm Mary Mercer. I'm the Chief of the Medical Staff at San Francisco General. So I'm delighted to present our report to you today, and thank you very much for the questions in advance. I'll answer a number of them during the report, and there are a couple that we'll need, we're still pending follow-up from some of the services. So the highlight of our most recent medical executive committee meeting was the presentation of our dermatology service report. And although our dermatology service is a relatively small service in terms of size of faculty, I think it really, the innovation, their focus on equity, and the way they have really utilized the many resources in an efficient and patient-centered way is really highlighted in their report. So for example, this time we had a different presentation, but it's in an electronic appendix. You can see the slides. But the scope of service is quite broad for the dermatology faculty. We do rely on a number of courtesy faculty and part-time faculty from UCSF as well to augment our on-site staff. And since the implementation of EPIC, they have been able to really take advantage of teledermatology with such a visually important clinical field. That's really helped expand access and timely treatment for our patients in our primary care settings by having specialists in dermatology weigh in on their conditions. I think they highlighted that's increased their volume to 5,000 instances annually, and really reduced the time to a provider and led to a cost savings and a patient experience improvement, so people are not having to come back to campus multiple times for visits with a specialist. They also highlight some of the work of their research and teaching, and I think given the small faculty size, it's quite notable that a number of the faculty that work at the General are recognized for their leadership in dermatology education, advancing equitable outcomes in dermatology, both for locally at UCSF and for national organizations. And a number of their work was highlighted in high impact journals. Really, our group is at the forefront of understanding and reducing disparities in dermatologic diagnosis and care. Other things that they noted in their report was moving into their rules and regulations updates. A number of the updates there were administrative, but some of them related to the expansion of dermatologic practice and for privileges to include procedures such as facial injections and other things which are part of core practices. So we added those to our privileges. And these are in part, part of our ability to provide equitable care to our patients who may need gender affirming care, as well as reconstructive services. Other notes from their report, I will take questions for should you have any. Okay, moving on. In our medical staff report, we also had a number of updated standardized procedures, particularly for our advanced practice professionals. So those are nurse practitioners, physician's assistants, and in some cases, certified nurse midwives. And thank you for the questions regarding, as some have mentioned here, we still have some version control issues as we're updating the names of the San Francisco Health Network and CHN, and those have been changed and will be submitted for your approval. Some of the highlights of the procedures that were updated and the perinatal space across multiple clinics represent collaboration between a number of our services to make sure that the same standardized procedures were being followed within our women's clinic versus our family medicine versus our internal medicine clinic. And so that was a great collaboration with input so that we could ensure that patients are receiving the same standard of care across all of our clinics. Other noted changes were mostly administrative in terms of adding some additional procedures in our pulmonary clinic and other areas. And I'm happy to take any additional questions there.
And again, no public comment on this item.
Okay. And then finally, there was a question and recommendation, and thank you, Commissioner Green, for sharing the ACOG recommendations around hepatitis, and sharing that back with our service chiefs for primary care, and we'll have an update to you, but I'm sure that that was an oversight from their part. And then finally, there was a question around the use of CNM definition being removed in some of our primary care clinics. I have a question out to our service chiefs around that. Some of that has to do, I believe, with staffing models, but we'll have a more robust answer for your questions in email follow-up to Mr. Morowitz.
Commissioners, questions on the report? Obviously, each of the departments that report, I think all of us find just amazing depth of service and research that is going on at the general. It's so hard to imagine that every department that you have reporting is just so sterling in the work that they're doing. It's something I think that I wish more of the public would really understand, and the education that they would get realizing what a high quality institution that we really have.
And as Dr. Ehrlich mentioned, in terms of the Bernard Tyson Award, I think you see as reflected in this report, a lot of the research and inquiry is really motivated by improving the experience of our patients and reducing health disparities that they experience.
All right. So, commissioners, any questions? I had some questions that are still sort of pending in my mind. For example, in one of the documents on page 20 out of 74, you're describing formularies as part of the standardized procedures. And I'm not sure what formulary, I mean, ZSFG has a formulary. Is that the same formulary as the health network?
Yes,
And is that
it
the
is.
same as the community? And are we trying to use the same terminology then?
I think the terminology may have not been as clear, so we'll make sure, but our formulary, our pharmacy is really network wide. And
Right.
so we are aligned across all of our clinical sites with that.
Okay, so in terms of speaking about community health network, then is that the same as the San Francisco Health Network?
Yes.
And it's just an older term again.
Exactly. We didn't find all of the find in place.
Okay. There was one in which on page 8 anyway of the document on the standardized procedures, you note that the approval of the procedure required MEC and Joint Commission and Joint Conference Committee approval, but then modifications didn't. So
I believe that I think that was an excellent point that you made, and we'll refer back to the bylaws, but my understanding is that modifications would come back to this body.
Right. Otherwise, all we do is
Right.
approve the original standard and you can all modify it as you go
Yes,
along.
exactly.
And we don't really have an opportunity to work with you on it. Okay.
And so Dr. Mercer,
So any modifications would come back to this body.
and the language would be changed in the final document. Okay, great.
Then I think this was more of a typo or trying to read through, and I wrote it for you already on page 6. And you just need to clarify what document somebody's signing before it goes on. The crossouts made it a little confusing.
The crossouts made
So it was only just to correct the language on that. Otherwise, I didn't have any other questions. Did you?
She addressed the ones I had.
Oh, sure. Okay.
Which were the
Very good.
definition of the midwife and then
Right.
adding this.
Yeah, and, okay, and all the perinatal stuff you've all approved of, because I just read them and said, well, we have an expert right here. So wait for her comments.
Yeah, it's just adding this, the more extensive hepatitis screening, which of course is so important in this population. And it just came out, I think it was August that it was recommended by ACOG, but I think it wasn't listed
As a
among the
specific-
standards, and it probably does need to be given, especially with the population we're caring for here.
I was happy to see that on, in the primary clinics, they are using the Asian BMI. Just wanted to note that that's really for East Asians. And you need to really go back and look again. There's been a lot of work being done on South Asians, and whether it's really applicable to South Asians is questionable. But of course, the majority of the Asian population here in San Francisco is East Asian. And so,
I will make a note of that as well and provide that feedback to the primary care clinic.
okay, good. Thank you. Any other questions? If not, then we'll, do we need an approval of this, right?
The recommendation that the Full Health Commission
To
approve
the-
these policies.
To the policies. Okay, so a motion is in order.
So moved.
All those in favor?
Aye.
Thank you.
Okay, thank you very much.
And we can move on to, I believe, item
Our next
7,
item.
other business. Thank you, Dr. Mercer.
Is there other business?
Hearing none, and there's no public comment, we can move on to item 8, public comment, and there's no public to, oh, I'm sorry, James Freeberg is noting that the privilege and the standard procedure modifications will come back to JCC and the language will be modified. He's the person who kind of does the work, my equivalent is confirming that that will happen. There's no public comment, so we can move on to consideration of a closed session.
A motion for a closed session is in order.
I move that we go into closed session.
Second.
All right, could someone close the door, please? Oh, thank you. Look, you're all ready.
We need to take a vote.
Oh, yes, please take a vote. But all in favor?
Please say aye.
Thank you. And again, noting there's no public comment on the item, and give me 30 seconds to take us over.
Okay.
We're back in open session. Commissioners, please consider a motion to disclose that you have approved the credentials report and PIPS minutes reports, and to disclose or not disclose discussions held in closed session.
I move that we disclose the reports that we are affirming and that we not disclose the other communications held during closed session.
Second.
All those in favor?
Aye.
Thank you. And then a consideration for adjournment.
So moved.
Second.
All those in favor?
Aye.
Aye.
All right, thank you, everyone. Give me 10 seconds to take us down. Thank you, everybody in the room and who were participating remotely. And a belated Happy New Year.